Thanks, everybody. So today I was going to talk about really management of coronary disease pre and post TAVR, talk a little bit about coronary obstruction at the time of TAVR, but then spend a fair amount of time talking about how to access coronaries after TAVR, what the risks are, the different valves, go over some cases that we've had at Yale, talk a little bit about coronary disease pre-TAVR and who we should fix and who we shouldn't fix and what the guidelines are. I think it's nice to have a little bit of an interactive discussion. I'm glad Theo reached out to me. This way I can call on her. It's perfect. So here are my disclosures, because this is a CME. You can click on the or text to get the credit, and Steve will post that. We already talked a little bit about this. This outline here, and so we'll start here. And really, the question of what is the prevalence of coronary artery disease in patients undergoing TAVR, and this really strongly depends on what patient population you are looking at. So if you look at the initial partner study, who looked at high-risk patients, you'll see that about 75% of them had coronary artery disease. So this was the initial partner study, right? Patients who were high risk for surgery, 75% of them had coronary disease. Conversely, if you look at the studies that have come out recently, and for example, the Evolute low risk paper or the partner low risk paper, what you'll see, and this is the Evolute low risk paper, is that your rate of coronary disease in this population is about 15%. Overall, the rate of coronary disease in patients with aortic stenosis is probably in the 35 to 50% range, but it certainly varies significantly depending on what patient population you are looking at. And as we've moved into lower patient populations, our percentage of coronary disease has certainly gone down. I thought next what I would just do as sort of an icebreaker here is talk a little bit about some recent structural heart referrals that we've had at Yale, who have raised the question of should they have a PCI, should they have a TAVR, should they have both, should they have neither, or should they have surgery? And so I'd ask the fellows to think a little bit about these, and they can unmute themselves in a couple minutes and we'll get their input. So the first is a 78-year-old male with severe aortic stenosis, progressive heart failure, and angina, and a prior CABG. His cath has a patent lima, a patent saphenous vein graft to a diagonal, and a large caliber right coronary artery filling via left to right collaterals, and his cath is unchanged from 4 years prior. Case 2 is a 72-year-old female with end-stage renal disease on dialysis, severe distal left main disease, proximal LAD and mid-RCA disease, an EF of 30%, severe AS. She's had a lobectomy for lung cancer, and she's having recurrent heart failure. Case 3 is a 76-year-old guy with distal left main disease as well, a 90% osteal RCA, normal EF, class 2 heart failure, and no angina. And lastly, case 4 is an 82-year-old male, 80% proximal LAD, metastatic prostate cancer to the brain, creatinine of 3.8, admitted from a nursing home with aspiration pneumonia, and has severe aortic stenosis. So these were all, as Hatel or Prabjot know, real cases that we've had in the not too distant past. And so I thought I would go over our guidelines for coronary artery disease before TAVR. And in the US, these are our guidelines. You're looking at them right now. And so we really don't have many guidelines from the ACC and the AHA about what we should do before TAVR. Now, we do have guidelines before surgical aortic valve replacement. And if we look at those guidelines, what you'll see is that coronary angiography is usually recommended, although there are some indications where doing a cardiac CT is recommended, and that if patients have coronary disease with a greater than 70% stenosis of a major coronary artery or greater than a 50% stenosis of the left main, then it's recommended that they undergo CABG or PCI. Although it's important to note here that the level of evidence is C for that. And when you look into sort of these guidelines and read a little bit before, what you will see is that there have been no randomized trials that fully support the use of concomitant revascularization in all patients with asymptomatic coronary artery disease undergoing a valve operation. While we certainly continue to do that, I do think that this is an important thing to note. There aren't any good randomized studies that have shown that these patients, who we all cath before they're having their valve replaced, and then say, oh, you know what, they have a 60% mid LAD or a 70% mid LAD or a 80% CIRC or an 80% RCA. There's no randomized data showing that that's fully beneficial. And I think certainly there is data that has come out with regards to the treatment of coronary artery disease prior to transcatheter aortic valve replacement. And there's a whole bunch of data. Most of these are looking at groups of patients through collaboratives, et cetera. This is one that came out of Europe, and here what they were looking at was survival in patients, and in red is incomplete revascularization, and in blue is complete revascularization. And you can see that there really was no significant difference when you looked at this between their revascularization complete versus incomplete. There was a little bit of a trend here when you looked at patients who had the higher syntax score, but again, none of this came close to being statistically significant. And the conclusion in this is that it may be safe to waive variable degrees of coronary artery disease without intervention. And pursuit of complete revascularization is certainly not a prerequisite for medium-term clinical success in an elderly aortic stenosis population, provided a rational and pragmatic approach to coronary artery disease by the heart team. And so I know Theo's on here, so I'll ask her to unmute herself, and maybe the other fellows can unmute themselves as well, and we can go back to these cases. So Theo, I'm going to call on you first because you're there. So a 78-year-old male with severe AS, the first one, what do you think?
So whether to, I mean,
Your
it's
options are PCI, TAVR, both, neither, surgery, etc.
I would go with prior coverage. TAVR, and let the RCA alone.
I think that's
RCA CTO alone.
I think that's certainly the right call in that patient there. And maybe Prabjot or Haytal, you want to take the second one? I can't see exactly who else is on the call, so I don't want to call on a fellow, or if there's another Theo, if you want to call on a fellow, you can see who's on, go for it. You can lead that.
I'm just
I'll
consenting.
pass the torch. I'll pass the torch to Rusty.
All right.
All right, comment. 72-year-old with end-stage renal, severe distal left main, Prox LAD, mid RCA, severe cardiomyopathy, severe AS, and prior lung cancer with lobectomy, recurrent heart failure. Yeah, it's tough to tease apart here. The benefit of a valve replacement without intervening on their severe distal left main Prox LAD disease. At the same time, not sure they're a great surgical candidate due to the lung disease and severe cardiomyopathy. So here I'd probably think about combination of TAVR PCI.
Yeah, so we talk a little bit about the combination of TAVR PCI. It is a challenging thing, and there is some data that's showing that complex PCI associated at the same time of TAVR, the patients don't do as well. It certainly can be done. Your hesitation to give protamine and other things are there. And so these are patients that a lot of the time what we'll end up doing, let me just get back to this, is doing a complex PCI with hemodynamic support, but also a balloon aortic valvuloplasty at the same time. This will help us in both knowing if this patient who has end-stage renal disease is going to get better some, we can fix her coronaries. And the way that we've started doing these is that we'll put in a large sheath to do our aortic valvuloplasty. We'll put in a smaller sheath for the PCI from the legs. If we think we need to rotor, maybe an 8 French sheath, but then, a 10 or a 12 for your balloon valvuloplasty. We'll do the balloon valvuloplasty and then put in a balloon pump right after the balloon valvuloplasty and do the PCI there. I think it is important for those who are doing these procedures to recognize that you don't want to be super aggressive with your balloon valvuloplasty. You're trying to, improve the gradient some, but you're not trying to get a perfect gradient. So if you look at the CT scan of these patients at the level of their aortic annulus, we often have a minimum diameter and one on one side and a maximum diameter when we measure it. I'll show a slide that outlines that. And so what we'll do is we'll size the balloon to the minimum diameter. Obviously, you're right, you're going to put a balloon pump in afterwards to help you with that. You don't want to have created severe aortic insufficiency in that setting. Maybe I can see now, Yolanda, you want to take the next one?
Sure. So the next one is a 76-year-old man with 80% distal left main disease, 90% ostial RCA disease, but has normal EF, CRES, and NYHA class 2. So definitely the coronary disease is significant with a distal left main and an ostial RCA, but it doesn't seem like he's having significant symptoms from them. I think based on probably on prognosis, we'll definitely try to fix the left main disease and ostial right. But I think the question, I think it needs to be fixed, but I think the question is what goes first, whether the valve replacement first and then the PCI, or PCI first and then the valve replacement. So that's where I think that's where the question would be. I think maybe he should get his PCI first. I don't think he will need hemodynamic support given the normal EF, and then later on the valve.
So I think that certainly is one option for him. I think the other thing to remember, and we involve our surgical colleagues in all these, is that a 76-year-old gentleman undergoing surgery or a CABG is unless he has other things going on, renal failure, prior strokes, is going to be pretty low risk. And so when you have distal left main disease and ostial RCA disease, I think that sent him for a CABG and surgical aortic valve replacement, and he did quite well. It highlights, I think, the importance of the heart team and having both surgeons and interventional cardiologists involved there. Maribel, you want to take the last one?
Sure. So 82-year-old male with known 80% proximal LAD, metastatic prostate cancer to brain, a creatinine of 3.8, admitted from a nursing home with aspiration pneumonia, dehydration, consulted for severe AS with a gradient of 40, an area of 0.9, and the EF of 55%. I'd probably let him recover from his aspiration pneumonia and dehydration and see kind of where he's at in terms of his symptoms, if his EF's normal, if he's symptomatic from his AS, and I'm not totally clear on what his prognosis is from his prostate cancer, but if it's metastatic to the brain, I'm not sure quite how much longer that gives you. So I would not be in a rush to intervene on him.
Yeah, and I think it's a great point. I think when you look at symptoms associated with aortic stenosis, I don't think you're going to find dehydration and aspiration pneumonia listed as common symptoms that come there. We're consulted on certainly patients like this a lot. This is somebody who, yes, has some degree of severe aortic stenosis, and people may say, well, he has poor flow, and that's why his creatinine is 3.8, and can't you fix that? And he has this LAD lesion, and can't you fix that? But his EF's normal. And so this is really somebody who's struggling because of their other things and whom we had recommended palliative care. And I think it's important to recognize that there is probably about, if you take all patients who have severe aortic stenosis, about 30 to 35% of them, based on the whole population, will probably have so many other comorbidities, or at least we know you take them that they're not going to benefit from interventions to your aortic valve when you're looking at high-risk patients. So there's sort of this group, cohort C of high-risk patients that when you look at all high-risk patients comprises about 30% of them that are simply not going to improve regardless of what you do. And doing any interventions is not going to make a difference on your morbidity or your mortality, even on your quality of life. This is somebody, you know, who was in progressive severe heart failure. Maybe you could consider just a palliative balloon valvuloplasty, but even in this patient's case, that's not what's going on here. So I wanted to move from those sort of decisions about patients into sort of the next stage, and that is what happens during the procedure and how do we think about things. So this is just a slide of what our structural fellows make up before each of the cases, outlining in this case a 79-year-old female. You can see she has what would be sort of considered that classic pear shape. She's 4'11". She weighs 96 kilograms. She has a BMI of 41. Certainly a lot of comorbidities, AFib. She has elevated systolic pressures, PA pressures. She has COPD. She's on home oxygen, history of anemia and bleeding, morbid obesity that we talked about. You can appreciate on her angio, she has some mild calcium in the left main. LAD has some mild disease. Right coronary has no significant disease and is dominant. And she's a lady who we deemed high risk. She had no iliofemoral disease that you can appreciate, I think, on the CT scan here, the significant amount of calcification in her distal aorta and in the proximal section here of her iliacs and common and external iliacs. So this is somebody who did have, as can be the case, good subclavian approach, and we decided to go with the subclavian approach in her. Here's just looking a little bit at her valve. One of the things that we look at is the sinuses. So this is looking at the sinus of Valsalva, and you can appreciate her sinus of Valsalva diameter is about 25 millimeters across all, 25 across the two, and then the left sinus measures about 27. You can appreciate her coronary height here on the left main is 12.4 millimeters, which is sort of in that normal range for coronaries. But you do get the appreciation. This is, if you haven't looked at these a lot, having a sinus of Valsalva that's 25, 20, 26 is actually a pretty small sinus. You can see the sinuses look pretty effaced. If you look at the picture here, it's not that they bulge out nicely like they normally do, but something that we, a fairly effaced sinuses as you're looking at it there. Here's her aortic annulus measuring 19.4 millimeters by 24 millimeters. So coming out with an area of about 350 and a perimeter of 67. And so when we think about sizing these valves, and this is an important thing to note, is that we have both at the top here is the sizing for the Sapien or the Sapien 3 valve, and at the bottom here is the sizing for the Evolute valve. And it becomes a little bit confusing because for the Sapien valve, we use sizing based off of area. And for the Evolute valve, we use sizing based off of perimeter. If we're talking sort of about the native annulus diameter, et cetera, that's here sort of 18 to 22, et cetera. So what you can see is that these valves are very different in many ways. One of them is actually in the sizing ways. So a 26 millimeter Evolute valve fits an annulus between 20 and 23 millimeters, okay? Whereas which is really the equivalent of a 23 millimeter Sapien valve. So when you say, the size valve that went, these two valves are equivalent in size with regards to the annuluses they go in. So a 26 Evolute valve goes in annuluses that are 20 to 23, and that's about where a 23 Sapien valve goes in. And so this patient meets criteria.
Hi, good morning.
They're a 23 millimeter Evolute valve. Now, what you'll also notice here, though, is that when you're looking at the evolute valve, there's one other restriction that's thrown in here, and that is the size of the sinus of Valsalva. So that's this measurement right here. And it recommends that you have a sinus of coronary obstruction when you have sinuses that are small. When you think about what we're doing in this case, we're taking the prosthetic valve, we're inflating it or deploying it, and we're pushing the native leaflets out to the side. And as we push those native leaflets out to the side, when you have a small sinus like that and you push those leaflets out here, there becomes a little bit of a risk of obstructing the coronaries, especially if this size is small, and especially if the coronary heights are small. And so here's this patient's case. Here we're taking on the first shot. You can see the 3 cusps of the aortic valve. Here's our deployment of the valve. We deployed it because we knew the sinuses were a little bit small, a little bit deeper than we sometimes do. We want to sort of be just below or at the level of the left main here, which we were, probably just at the level, maybe a touch above the left main here. And here's our shot afterwards that shows, everything looks pretty good. So we were happy with this. You can see there's nice flow down the coronary arteries here. And so we're doing this case with Dr. Mangi, and took out the sheath. We gave protamine. We were working on closing up the rest of the patient when the patient developed severe hypotension. And severe hypotension in the setting of a transcatheter valve procedure is always very concerning. We're always worried that something's going on in that case. And it's very important, I think, similar to when you develop severe hypotension during a percutaneous coronary intervention, that you really have a preformed differential diagnosis in your head. I think the first thing we always worry about is bleeding, that the bleeding from the groin or bleeding from somewhere else or bleeding from the subclavian access. The next is that we have potentially have a pericardial effusion. In these settings, especially if there's a lot of heavy calcification around the valve, and when we're using balloon expandable valves, we worry about the risk of annular rupture. Protamine reactions actually can occur and can cause some degree of hypotension. We don't give a lot of protamine in the cath lab for coronary cases, but we give it all the time for these cases. And you do have at times where there's protamine reactions. In talking to our surgeons, they've in fact had protamine reactions so severe that they've lost the patients at the end of surgeries due to severe protamine reactions, which can cause a lot of vasodilation and severe hypotension. You have to worry about coronary obstructions, obviously the topic of this talk. Worry a little bit about valve dysfunction, and of course worry a little bit that the anesthesia resident gave something that they didn't tell you what it was. So the question is, what do you do next? And I think this is a good lesson for all of the fellows, even us as attendings, and that is that when you have a patient who has hypotension after a cardiac catheterization procedure or after a TAVR, the first thing to always do, and as quickly as you can, is to get an echo. And the reason that you want to get an echo is that you can evaluate pretty well, do we have an effusion? Do I have an annular rupture? Do I have valve dysfunction? Do I have coronary obstruction? You can look at the IVC, et cetera, and understand, is everything underfilled and I'm worried about bleeding here, et cetera. And here you can see this patient who had normal left ventricular function before, now has significantly depressed left ventricular function. It's fairly focal, raising the concern for the possibility of a coronary obstruction that is occurring. And so we re-engage this patient's coronary artery, at least we work to re-engage the patient's coronary artery. And what you can see here is that as we engage the coronary, there's a tight area right at the ostium of this of the left main here. And what's happened here, and I won't go into too much detail, is that you've taken this native leaflet and we've pinned the native leaflet up against the close to the ostium or very near the ostium of the left main. We haven't fully obstructed that left main, or it didn't occur immediately after the valve went in. But in the setting of giving protamine, et cetera, we did close off that left main. That small opening that was there closes off and causes the patient to go into profound shock. By simply putting in this catheter, we actually push the leaflet down a little bit, and so we restore some flow. It's clearly there's still osteal stenosis there, but there's some flow here going down the left main, and we'll talk about how we manage this in a few minutes. But first, I wanted to talk about coronary obstruction and transcatheter aortic valve replacement, its frequency, and its risk factors. So there's been a lot written about this, a number of review articles, et cetera. But I put together a little table here to try to summarize that I think summarizes it nicely. I think the first thing to know is that it has a fairly low incidence. It occurs in less than 1% of cases, about 0.5% of cases. It does tend to occur more in females than in males, and that's because females tend to have smaller anatomies. And really what's going on here is you're occluding the coronaries because of the native leaflets that are getting pushed to the side. In rare instances, if you mal-deploy a valve or deploy it super high, you can actually block off the sinuses. But in the vast majority of cases, it's because a leaflet has obstructed it. 50% of them are actually partial occlusions, and 50% are complete occlusions, which the complete ones, obviously, you're very aware of them on the table. But in some post-mortem exams, what's been shown is that, we had one patient a couple of years ago who had VT and VF about 24 hours after their valve was in. And while that patient didn't have an autopsy, a number of cases have looked at patients like that and have found that they've had late or sort of semi-late complete coronary obstruction. So probably had partial, but still with flow down, and then in the setting of being reversed and other things. And we know that some thrombus can form in the sinus of Valsalva. They end up with complete coronary obstructions. It also does tend to affect the left main better than the right coronary artery. And there are two main anatomic characteristics when we look at the patient's CT scan before, and that is that they have a small sinus of Valsalva. We talked a little bit about that before, looking at the size of the sinus of Valsalva, or they have low coronary heights. Interesting, there is this trend towards it occurring more for balloon expandable valves than for self-expanding valves. Here's looking at for surgical aortic valves, and here's looking at, this isn't surgical aortic valve, this is looking at native aortic valves, so a TAVR and a native aortic valve, and this is looking at a TAVR for a valve in valve, so inside a surgical aortic valve. You'll see first that the rate inside of surgical aortic valve is significantly higher. The reason for that is in surgical aortic valves, often the surgeon has implanted the surgical valve actually a little bit higher than the native valve is, where it's located in the aortic anatomy. And so those leaflets, when you push them out to the side, can have a higher risk of obstructing the coronaries. This difference that you see between self-expandable and balloon expandable valves, this probably doesn't have anything to do with the fact that you're having one valve increasing it more than the other. Really what I think it has impact of is this fact here. And that is that in this patient, our chart says don't put in an evolute valve because sinuses aren't big enough. For the SAPIEN, there aren't those warnings. And certainly there are cases where, putting a SAPIEN in here, putting it in a little bit lower works. And so I think it's the fact, not that one is causing it more than the other if you were to do them equally, but there is a significant tendency when you are a little bit borderline, although this is probably, maybe it has changed a little bit. This is back in 2013, and we can now recapture these self-expanding valves, but there was a tendency to use more balloon expandable valves. And these sizing guidelines for the native sinus still exist. So the management of these patients, it's important to have PCI equipment easily accessible, have either some sort of cardiopulmonary support or balloon pumps ready to go. In high-risk cases, we often consider prophylactic coronary protection with a guide wire and or a stent. We often, in high-risk patients, consider the use of a transesophageal echo for it. And also, one thing that can be done is at the time you're doing your TAVR, when you inflate your balloon for your aortic valvuloplasty, there can be a role of taking an angiogram to see if there's flow down the coronaries at that time. With the balloon inflated, as you can think about it, you've pushed the you've pushed the aortic leaflets out to the side. And certainly there are instances where when you do that and you inflate and you take an angiogram in the aorta, you see that you obstruct flow down the coronaries. That's a situation where if you see that, you're not going to want to proceed forward with your TAVR. But I will highlight that even if you still see flow down the coronaries when you're doing that, that doesn't necessarily mean you're going to be totally safe when you do the TAVR and not obstruct the coronaries. But if you do see that you've obstructed flow down the coronaries during your balloon valvuloplasty, you really need to reevaluate how you're going to move forward from there. I think often we think in patients who have small sinus of Valsalva and low coronary heights that surgical aortic valve replacement, especially in low or intermediate risk patients, is something to strongly consider. That sort of anatomy that's not as favorable for a transcatheter valve. And we in fact have had a number of cases who have had small sinuses and low coronary heights that we've sent to surgery. I will make the highlight that obstructing the coronaries with surgery can happen as well. And we actually had one unfortunate case where we had a patient whose coronaries were incredibly low, left main coming up about 6 millimeters above the level of the annulus, just way, it was an intermediate risk patient. We sent him to surgery and probably didn't communicate as well as we should have with our surgical colleagues just how significantly concerned we were about the left main. The patient went for surgery. After the valve went in, they came off bypass. Really, their entire anterior wall was down. They emergently put a lima onto the LAD, figuring that's what might have happened, but the patient actually didn't end up surviving outside of the hospital. So communication with the surgeons in those settings is always important. And we talked a little bit about self-expanding versus balloon expandable. So this is what we did in this setting. We wired it with the guide that was there, advanced the balloon, and then eventually stented that area there, hanging back into the left main a little bit. And now you can see, right, where what had been very pinched before, the ostium here is now nice and wide open. In this case, we used the JL4 guide. We'll talk about this next. Stented with the 4012 drug-eluting stent, and the patient had great recovery. Actually had recovery of the LV function in the cath lab and was discharged home on postoperative day 3. So in the little bit of the remaining time, I want to talk about coronary access after transcatheter aortic valve replacement. Certainly, this is something that we're seeing more and more frequently. I think it's important to note that clinical data has shown that coronary access post-TAVR is technically feasible, and most have reported fairly positive outcomes, high rates of PCI success, somewhere in the 90% range. Some showing 100%, but again, these are small, relatively small studies. You get into the bigger studies, you tend to be more in the 90% range. That being said, reaccessing the coronary arteries after a TAVR, especially when the frame of the TAVR extends above the coronary ostia, as it does with the Evolut or core valve family of self-expanding valves, is definitely not always easy. There's a recent study that came out at the end of last year, I think around November, which was the ReAccess study, which I think lends some insights here. So in this study, 300 patients had coronary angiography performed before and after their transcatheter aortic valve replacement. 123 of the patients had the Evolut valve, which is the self-expanding valve that it's supraannular where the valve is, and the frame extends above the native coronary arteries. 96 of them had the SAPIEN 3 or SAPIEN Ultra valve, which is the Edwards balloon expandable valve. I'm not going to get into too much about the Accurate Neo and the others. They're not valves that we have here presently. And here's what you can see. And so looking at their success rate for engaging the left coronary and the right coronary before the TAVR, it was perfect. And then if you look afterwards, engaging the left, they were able to selectively cannulate it in about 83%, semi-selectively cannulated in 12%, and were not able to cannulate it in just under 5%. And then with regards to the right coronary artery, selectively engage it in about 65%, semi-selectively in little over 30%, and weren't able to engage it in 4%. I think what's important to note here is that of the 23 cases where the coronaries could not be reaccessed, 22 of those were with the evolute valve, which is a supraannular valve. And the reason for that, we've come to learn more and more now. So if you imagine right now that you're sitting in the distal left main and you're looking out the coronary ostia. So you're looking out towards the aorta and somebody's just put a valve in front of you. This is what you see this is what you may see with a sapien. So what you may see is that your commissures are aligned nicely. Here are your commissures on 3 sides, and you're looking out into open space. So it's fine for you. You could go out and you could hang out freely there, and somebody coming into your coronary ostia would be fine. However, we don't put these valves in all the time in the anatomic correct position. So the commissure is right here, this commissural post. And so you could be looking out into this. So you could be looking out, and straight ahead of you is this large commissure that extends up to, heights here. This is 18 millimeters above the level of the annulus, and you're located down here. So when you're looking out, you're seeing this. Now, because of the size of the sinus, there is space between the coronary ostia and here. But you can imagine just how difficult it's going to be to get a catheter to engage when you have this that's a few millimeters away from the coronary ostia. And so that's what can make it really challenging in cases with evolute valves to often purely selectively engage the coronaries. If you have this commissure which is not lined up properly, it's going to be difficult, if not nearly impossible, with a guide catheter to selectively engage it. Now, there are some tips and tricks, and that's what we're going to talk about here. But I just want to make sure that makes sense to everybody, right? You have the way this valve is and the commissures that are here. If you have this commissural, in essence, almost post, not a post, but you can think of it that way. If you have this and it's lined up in front of your coronary, it's going to be very difficult to selectively engage that coronary artery. So we've actually had 3 cases in the last 3 months. When I first gave this talk, there was 3 cases in the last 2 weeks. They all seem to occur next to each other. 2 of them were STEMIs and TAVR patients. One was a patient who was 7 days out, who ended up with HIT, had a PE and a coronary thrombus in the LAD. One was 3.5 years out, who had an acute plaque rupture in the RCA. And one was an elective PCI for a TAVR in a patient 3 years out who needed a PCI to the LAD. And so in all of these, this is what you're trying to do. We're going to end up coming through this valve frame. We're going to hope that this commissure, right? You can imagine if this commissure here is placed over here, it's going to be really hard to selectively engage it. So we're going to hope that's not the case in the commissure. And I wanted to go over sort of 5 tips and tricks for how all of us as interventional cardiologists want to think about engaging these arteries when you have a transcatheter valve in place. And so this sort of summarizes them, and I'm going to go through them one by one. But the first is to at your baseline, a lot of us are used to using EBUs or other catheters. I'd recommend using a JL guide if you're trying to engage your left coronary, or a JR guide if you're trying to engage the right coronary. I'd recommend downsizing by 0.5 centimeters. So if you usually use a JR4, try using a JR 3.5 similarly for your other catheters. And we're going to go through these. So first, right, use a JL or a JR. And the reason for that is that, our EBUs and our other catheters that tend to omplots are going to have a difficult time coming directly through here. And you're going to get plenty of backup support simply because of the frame of the valve that exists. You're not going to need other backup support, but what you are going to need to be able to do is come from above and try to come through the proper cell that's here. Because of that, and you can think about this valve here almost makes the aorta smaller, right? It's compressing your catheter, and that's why we also want to think about downsizing. As you guys know, JRs and JLs come in a variety of sizes. I rarely use JL guiding catheters when doing coronary interventions in native coronaries, but that's my go-to guide when I'm doing transcatheter valves, especially Evolut valves. Again, as we talked about here, the frame provides support, which allows for the use of the standard shape catheter. The second thing we're talking about here is because of this frame, because of the way it works, try downsizing when you start by 0.5 centimeter. So whatever you would have done, try downsizing by 0.5 centimeter, and you may find that that helps you. Now, not necessarily, if it doesn't work, the next thing you can go to would be what your normal size guide would be. But I would recommend trying to downsize by 0.5 centimeter. This may just allow for a little bit more maneuverability and flexibility to reach the coronary ostia. The next thing, and this is another thing, is that we often, when we're engaging coronaries, when we're engaging the right coronary artery, we start low and we clock and we pull up and we allow all that torque to transmit. And when we're engaging the left coronary, we may start, below it and counter the catheter to move it before we engage it. That doesn't work well in these settings. Really, in these settings, what you need to do here is that you need to figure out where this node, where this frame is that you're coming from, and you need to aim for that, and you need to be coaxial with the coronary. So starting super high or super low above it's not going to help you. You're going to end up coming through one of these frames up here, as opposed to coming through where you want to. These cells on the valve are plenty big. You can put a 10 French catheter through them, so you shouldn't have a problem getting through the cell. That being said, the cell that you get through may not lead directly to the coronary, and in fact, depending on how these cells are, there may not be a cell that perfectly leads directly into the coronary, such that your guide is going to be able to perfectly engage the coronary. If you remember back to that paper that I had shown, in about, for the left and the right, in somewhere around 15 to 30% of cases, you're going to end up non-selectively engaging the coronary artery. Please, if there's questions or other things, I don't have the chat, but Steve, interrupt me, or anyone else if they're paying attention to the chat, or if people have questions. So what if that doesn't work? If the coronary engagement is unsuccessful, consider changing the guiding catheter size. I often will try to target an adjacent open frame cell, and then often we'll attempt partial selection, engaging with the wire and using a guide extension catheter. So this is what's had happened a fair amount, and what you will find is that if you can't selectively engage with the catheter using a wire, and then a guide extension catheter can really help in these instances. So use guide extensions. Last thing that I want to say, and this isn't something that you will probably have thought of before, but that is to remove the guide catheter over a wire. And so as you can see here, that when you're disengaging your guiding catheter, they actually are pulling it back while the wire is still down the coronary artery. The reason for this is that there have been a handful of cases where if you pull out the wire first and sort of take a final angio with no wire in there at all, and then you pull back your guide catheter, instead of coming straight back, it wedges up into one of these frames here, and it can get really stuck in those frames. the tips of these are pretty smooth, but they're not perfect, and you certainly can malform them if you play with them. And so if you end up pulling up and your force is up with this, you can actually get the tip of this catheter stuck in the valve frame. And there have been some not fun cases that have occurred as a result of that. None of them here, but ones that we've seen around the country. And so, as you're doing this, counter your catheter as you normally would and pull back, but pull back with your wire still down the coronary artery. I do want to say that the right coronary artery is often more difficult to selectively engage through the evolute valve. We saw that in the ReAccess trial, where about 30% of cases of patients with regards to the right coronary artery, you cannot selectively engage. Again, we want to aim for this target zone. You want to come down there and you want to clock the catheter to try to get in here. But here's an example of where you're not able to fully engage it in a patient who's had has an inferior wall mine. You can see this large thrombus sitting here in the mid right coronary artery. This is good enough. You can take that from there. You can pass your wire down. In this case, it looks like they passed the angiojet as well. You're a little offshore. If you need to put a guide extension catheter down, you can, but you'll often find even when you're offshore that with some manipulations, your guide will eventually fall into place and you'll be able to get down to the artery. So use guide extensions liberally, and don't be afraid of doing that. And don't be afraid of starting to wire when you're non-selectively engaged. Having that wire down there will help you a lot. I want to finish just here and save 5 or 10 minutes for questions with the valve-in-valve concern. And the main concern here is that when you're putting in, so here's a Sapien 3 valve inside a Sapien XT valve, and you can see the old valve here's the leaflets of the old valve. It gets pushed off to the side. And if you do that in your valves like this, it's going to be nearly impossible to re-engage the coronaries. Now, this is a patient who has low coronary heights. If the valve's been implanted a little bit lower, you may be able to re-engage them, but it's going to be tough. When we're talking about evolute valves, it's even more difficult. So this is what happens, right? You have a supraannular valve. You're creating a stent graft that's extending here nearly 20 millimeters up. And it's going to make it totally impossible when you're doing a valve-in-valve to engage it the way we talked about, being coaxial. The only way you're going to be able to do it is to come up through here and down and around. And so this is an issue. It's going to both make coronary access quite difficult for these, and also in a large number of patients really increases the risk of coronary obstruction. There are some cool ways to get around this. For the sake of time, I'm going to skip over some of that, but this is the Basilica procedure, where in a patient like this, where we have really low coronary heights, what you in essence are doing is splitting the leaflets. And so if you take a valve here, so here's a valve-in-valve, here's the old surgical valve. You can see the same thing happens with the surgical valve when we push it to the side. But if we electrify a wire and poke it through this valve before we've done the valve-in-valve procedure and then do it, we create this slit in the valve. This is how that works. You take one catheter with a snare, a gooseneck snare. You take another catheter, you electrify the wire, you pass it down through the valve into the left ventricle, you snare it in the left ventricle. You then create a rail here that has a little bit of wire there. You electrify that and you pull this up, and then pulling that up, you create this tear in the valve, and then you do your transcatheter valve to allow blood to flow down through there. Been done a lot. It can help certainly in some cases, but it's clearly proven that it doesn't always help, and you still can at times get coronary obstruction. There's some pretty cool things out there that are looking at the CT modeling for the risk of coronary obstruction. These are in some of their early days. I know Andreas is on, so I don't know if he's done any work, but I know they've done a lot of work with CT modeling over at the UK. I'll finish just with some take-home points. So first, the decision of PCI pre-TAVR should be rational and pragmatic, driven by a dedicated heart team. Coronary obstruction during TAVR is rare, but be prepared. Risks include small sinuses, low coronary heights, and especially valve-in-valve. Engaging the coronaries, especially through the evolute frame, requires modifications to your regular routine for coronary angiography. If the commissures of the native valve and TAVR are not aligned, this may require non-selective engagement, offshoring of the wire, and use of guide extensions. And valve procedures really increase the risk of coronary obstruction, especially TAVR and TAVR procedures due to the creation of a stent graft, which also is going to make coronary re-engagement especially difficult. And this should be thought about a lot, especially in younger patients when we're thinking, they're going to need a valve procedure. And after they've had their valve procedure, if we're really with that procedure, either risking coronary obstruction or saying after your valve, we're never going to get back into your coronaries, a lot of thought needs to go into that. So we'll finish there. Thanks, everyone. And we should have some time for questions.
Hey, John, can you hear me?
Yep.
Hey, it's Costin. Hey, great talk. Thanks for sharing, your knowledge. Two questions. One is durability of the valve, meaning should we be concerned when you try to engage the coronary on being aggressive with guides and, extension and just, pushing in that valve from various angles and torquing the catheters? And two, if we do have the JR 3.5 in the lab.
3.5, although I'm not positive.
Okay.
On the first question, these valves are pretty durable. Obviously, you don't want to be ramming stuff around there. I think you want to figure out, where's your coronary height, and work to to engage it by coming in at that level through the valve frame. I will say that, we have the benefit of having all of these patients or almost all of them have had a coronary angiogram before. And I would highly recommend that you don't just look at the report of what was done before, but look at where the coronaries actually were coming off and try to find your landmarks from the diagnostic cath that had been done before, even in the setting of a STEMI. Take the minute it's going to take as the table's being prepped or something else to look, what did this patient's diagnostic cath look like? Where are the coronaries and what am I dealing with? I think often we don't look at those, and especially in these cases, there's great value to understanding where the coronary is coming off, et cetera, because if you're struggling there, you're going to be like, geez, I'm not sure where the coronary is coming off. And you have the ability to know exactly where it is. Just look in the medical record at the patient's prior cath.